So, my dear students, you are in class, and I pray to Almighty God for your healthy life, and hope you will continue your study and prepare yourself for next exam. And today we will discuss the university question on rheumatology. It is. So our first question is, a 20 years old male presented with low back pain for 2 months, which become worse at night with morning stiffness for more than 1 hour. And what is your possible diagnosis? And our possible diagnosis is ankylosing spondylitis. And our next question was, write down the extra-articular feature of this disease. And the extra-articular features of this disease, in eye we will get conjunctivitis, uveitis, and prostate gland and prostatitis, which usually occurs after 40 years of age in male. And next, cardiovascular disorder, aortic regurgitation, mitral regurgitation, complete heart block, and pericarditis. In lungs, apical fibrosis of the lungs can occur. Now, what investigation we can do for this patient? This is the third question. And here, ESR of blood will be raised, and HLA-B27 is positive in most of the cases. And in ECG, we can get your complete features of complete heart block if complication develops. And X-ray of the SI joint, reduced joint space, marginal sclerosis. And X-ray of the lumbar spine shows marginal sclerosis, calcification of the anterior longitudinal ligament, squaring of the vertebra, bridging this syndesmophyte formation, all this giving the appearance of the lumbar spine, a bamboo-shaped spine. So this is regarding the investigation of ankylosing spondylitis. Now our second question. A 55 years female presented with history of pain and swelling of the right knee joint for 7 days. That means monoarthritis. And what history we can get for diagnosis? And sudden severe joint pain with red hot joint suggests septic arthritis. If the joint pain and swelling occurs very rapidly and the joint is red and hot, it indicates septic arthritis. And if history of bacillary dysentery or sexual exposure prior to arthritis, that suggests reactive arthritis. And if pain and swelling of the right metatarsophalangeal joint along with the knee joint, that indicates gouty arthritis. So this is the relevant history for this patient. Now investigation. Total count of WBC, leukocytosis and septic arthritis. Leukocyte count will be very high in case of septic arthritis, and that is neutrophilic leukocytosis. ESR and CRP is also raised. Uric acid level is increased in case of gouty arthritis. Chlamydia test for high vaginal swab may be done if it is positive, that indicates reactive arthritis. And culture sensitivity of the synovial fluid, it will be positive in case of septic arthritis. Now, how we can treat this septic arthritis patient? A specific treatment of septic arthritis is injection flucloxacillin 2 gram IV 6 hourly for 4 weeks. and injection ceftriaxone 2 gram IV daily for 4 weeks. In 2 to 4 weeks, if we suspect and there is chance of gram-negative bacteria, and aniside naproxen sodium BD for 2 to 4 weeks can be given. And in general measures, immobilization of the joint during acute stress and aspiration of the joint fluid frequently can be done in aseptic manner. So this is regarding the second question. Now our third question is a 25 years old female presented with fever, oral ulcer, malar rash, alopecia, and leg edema. What is our diagnosis? Our diagnosis is SLE, and investigation. What investigation we can do for this patient? ESR will be high, hemoglobin reduced, WBC also reduced, Coombs test positive, and in case of acquired hemolytic anemia, ANF is positive in 95% cases of SLE, and double stranded DNA antibody positive only in 30% cases of SLE. And we can do also urine, where we can get RBC, hyaline cast, and albumin. 24 hours urinary protein can be done if we suspect that is lupus nephritis, and more than 500 milligram proteinuria suggests nephritic illness. X-ray of the chest can show fibrosis of the lungs or even proliferation of the lungs. Echo can show valvular lesion. So all these are the investigations for SLE patient. Now question number third question of this part, what are the autoimmune disease, or tell 4 autoimmune disease. One is Graves' disease, pernicious anemia, type 1 diabetes mellitus, and Addison's disease. These are the 4 autoimmune diseases like SLE. Now question number 4. An obese elderly hypertensive patient presented with severe pain and swelling of the right great toe of the right foot. What is your clinical diagnosis? Our clinical diagnosis is acute gout. And next question, name 4 predisposing factor of this patient. And the predisposing factors are the red meat, alcohol, CKD, drugs like pyrazinamide and thiazide diuretics, and seafood. Now treatment. A specific treatment of gout, naproxen sodium 500 mg BD, tablet colchicine 0.5 mg, 1 tab BD till pain subsides. Tablet allopurinol 200 mg, 1 tab BD, it can be increased according to response. And if response is not satisfactory, then we can give tablet febuxostat 1 tab BD. Tablet probenecid, spelling mistake, probenecid, it can also be given in chronic case. And general measures, avoid high protein diet and drugs like thiazide, pyrazinamide, etc. Now the question number 5. A 30 years lady presented with painful swelling of the right elbow joint, and he has history of sexual exposure 2 weeks before. How will you investigate this patient? Blood ESR will be high in case of reactive arthritis. CRP also raised. RA test is negative in reactive arthritis. And high vaginal swab test gram staining to detect gram-negative diplogocci in gonococcal infection. And Another test we can do from the high-vaginal swab, that is NAT test for chlamydia. An X-ray of the involved joint space is reduced and there is periarticular osteopenia. And X-ray of the lumbar spine can show. Mention 4 disease-modifying anti-rheumatic drug. 2 biological DMRD. One is infliximab and second is etanercept and third is rituximab. These are the 3 biological DMRD. And non-biological DMRD are MTX and hydroxychloroquine. Now question number 6. A 43-year-old female presented with polyarthritis involving small and large joints for 3 months. A 43-year-old female presented with polyarthritis involving small and large joints for 3 months. Mention 4 differential diagnoses. And the 4 differential diagnoses of this patient are rheumatoid arthritis, SLE, psoriatic arthritis, and ankylosing spondylitis. Mention relevant history in favor of your diagnosis. For rheumatoid arthritis, we can take history, multiple joint pain, large and small joints, symmetrical involvement of the joint, especially the hand joints are commonly involved, morning stiffness more than 1 hour. For SLE, fleeting type of polyarthritis, no symmetrical involvement and associated with the skin rash and oral ulcer. For psoriatic arthritis, history of psoriasis and asymmetrical arthritis in 75% cases, and usually oligoarthritis, but polyarthritis only in 25% cases. For ankylosing spondylitis, low back pain with restriction of the back movement and usually oligoarthritis, peripheral joint involvement, and asymmetrical. How we can investigate this patient? For rheumatoid arthritis, we can do ESR, CRP, anti-CCP antibody, and RA test. These are supposed to be positive. And X-ray of the hands, soft tissue swelling, multiple sclerosis, joint space narrowing, and marginal erosion. These are the findings of X-ray hand in rheumatoid arthritis. And for SLE, ESR high, ANA positive in 95% cases, anti-double stranded DNA positive 30% cases. Urine can show RBC, cast and albumin, hemoglobin reduced, comb test positive, X-ray chest, fibrosis of the lung, echovalvular lesion. For psoriatic arthritis, RA test negative, RA test negative, and so reactive arthritis is not, it should not be included here. Here we should include ankylosing spondylitis, and investigation of ankylosing spondylitis should be done. And where we will get RA test negative, ESR high, C-reactive protein high, X-ray of the spine, syndesmophoid formation. Now question number 7. A 18-year boy came with history of abdominal pain and swelling of knee and ankle joint. On examination, he had palpable purpura in lower limbs. What is the most likely diagnosis? Our most likely diagnosis is henoxalin purpura. How will you investigate this patient? Blood test will show platelet count normal but ESR high, and urine can show proteinuria and hematuria due to nephritis. And treatment is prednisolone 1 mg per kg body weight for 4 to 6 weeks. Now question number 8. A 18-year girl presented with fever, anorexia, lethargy and joint pain. 2 to 3 weeks prior, she had history of sore throat. What is your diagnosis? Our diagnosis is a rheumatic fever. Write down the point in favor of your diagnosis. History of sore throat, 2 to 3 weeks back indicates evidence of streptococcal infection, and which usually occurs in rheumatic fever. And fever is a minor criteria for rheumatic fever. Arthritis is a major criteria for rheumatic fever. How will you manage this patient? Treatment of sore throat. Tablet phenoxymethyl penicillin 250 mg, 1 tab 6 hourly for 10 days. And tablet aspirin 300 mg, 2 tab TDS, uh, continued until ESR is normal. And for secondary prophylaxis, tablet phenoxymethyl penicillin 250 mg, 1 tab BD for 5 years, or injection benzoyl penicillin 12 blocks IM monthly for 5 years. And in case of carditis, treatment should be continued up to 40 years. Now the question number 9. A 20-year male presented with red eye, swelling of the right knee joint, ankle joint, tarsal joint of foot. He had history of bacillary dysentery 3 weeks back. What is your diagnosis? Our diagnosis is a reactive arthritis. Write down the extraarticular manifestation and investigation of this patient. Extraarticular manifestation is, here it is wrong, it will be succinate balanitis, printing mistake, not cortical blindness, it will be succinate balanitis. And next is keratoderma blenophagica, and third is nail dystrophy, and fourth is buccal erosion. These are the 4 extra-articular manifestation of reactive arthritis. And what investigation? ESR and CRP is raised, are test negative, high vaginal swab for NAT test for chlamydia, X of the involved joint, periarticular osteopenia, X of the lumbar spine, syndesmophyte formation. Now treatment of reactive arthritis. Specific treatment, NSAID, naproxen, 500 mg BD, tablet disease-modifying drugs like sulfasalazine 500 mg, half tab BD for 7 days, 1 tab BD for 7 days, then 1.5 tablet BD for 7 days, then 2 tab BD continued for 1.5 years. And tablet MTX 2.5 mg, 3 tab once in a week with folic acid once in a week. And in case of anterior uveitis, patient should be treated by topical and systemic steroid. So now this is the last question of today's discussion. Write down the common features of seronegative spondyloarthritis. The common features of seronegative spondyloarthritis are sacroiliitis, and oligoarthritis, asymmetrical oligoarthritis, enthesitis, and HLA-B27 positive, and seronegative arthritis. These are the 5 common criteria for spondyloarthritis. And what are the non-articular manifestation of rheumatoid arthritis? In eye, conjunctivitis, scleritis and uveitis, and in heart, aortic regurgitation, mitral regurgitation, pericarditis, and conduction defect. In lungs, fibrosis and proliferation and pulmonary nodule formation. And in GIT, the side effect of the NSAID, that is peptic ulcer disease, and in skin, pyoderma gangrenosum, nervous system, carpal tunnel syndrome, tarsal tunnel syndrome, mononeuritis multiplex, and lastly, Feltis syndrome, rheumatoid arthritis with lymphadenopathy. So this is the end of today's class, and I pray to my Almighty God lastly for the healthy life of my students and peaceful life of for my patient students, so that they can continue their study and they can prepare their lesson and they can get preparation for the coming examination. I hope best for them. So thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Assalamu alaikum, sir.
Thank you, sir.
Thank you.